Hey guys, it's Steve, and today I'm going to try to read directly from Wikipedia just because I have the time and I have a good radio voice, so why not? Um, it's going to be reading about borderline personality disorder. If you guys haven't subscribed to my channel, you can push the subscribe button, push the like button, help get the knowledge out to other people about borderline personality. This video, I always tell people that I don't bash on borderlines. Borderlines do have good side. Everybody has a good side and an evil side. I'll say that till I die. I mean, you could take a serial killer, and I guarantee that person has a good side. Um, Everybody's got a good side and an evil side, guys. So by no means do I mean to bash on anybody. So borderline personality disorder, according to Wikipedia. Borderline personality disorder, also known as emotionally unstable personality disorder, is a personality disorder characterized by a long-term pattern of intense and unstable interpersonal relationships, distorted sense of self, and strong emotional reactions. Those affected often engage in self-harm and other dangerous behaviors, often due to their difficulty with returning their emotional level to a healthy or normal baseline. They may also struggle with disassociation, a feeling of emptiness, and a fear of abandonment. Symptoms of BPD may be triggered by events considered normal to others. BPD typically begins by early adulthood and occurs across a variety of situations. Substance use disorders, depression, and eating disorders are commonly associated with BPD. Some 8 to 10% of people affected by the disorder may die by suicide. And if you have a borderline personality relative and they're threatening suicide, you need to take it seriously because that means they're seriously considering it. Borderline people get suicidal thoughts often. So if your friend's borderline, your sister, your brother's borderline, and they're talking about suicide, you need to take that threat seriously. You can call 988, the suicide helpline. So we're going to keep going with that, guys. With the rate of being twice as high in males as in females, so more men commit suicide than women. The disorder is often stigmatized in both the media and the psychiatric field, and as a result is often underdiagnosed. The causes of BPD are unclear, but seem to involve genetic, neurological, environmental, and social factors. It is 5 times more likely to occur in a person who has one or more of the affected immediate relatives. Adverse life events appear to also play a role. The underlying mechanism appears to involve the frontolimbic network of neurons. BPD is classified in the American Diagnosis and Statistical Manual of Mental Disorders, DSM, as a cluster B personality disorder, along with antisocial, histrionic, and narcissist personality disorder. BPD and other personality disorders can be misdiagnosed as a mood disorder, substance use disorder, or other disorder. BPD is typically treated with psychotherapy, such as cognitive behavioral therapy or dialectical behavioral therapy. Therapy for BPD can occur one-on-one or in groups. While medications cannot cure BPD, they may be used to help with the associated symptoms. Quantapine and SSRI antidepressants are widely prescribed for the condition, but their efficacy is unclear. And you really want to monitor for psychosis when your girlfriend's on medications. BPD girls can go into psychosis, so you really need to watch that as well. A 2002 study found fluvoxetine and SSRI significantly decreased rapid mood shifts in female borderline patients, while more recent meta-analysis found the use of medications still unsupported by evidence. Severe cases of the disorder may require hospital care. About 1.6% of people have BPD, with some estimates as high as 5.9%. Women are diagnosed about 3 times as often as men. Up to half of those with BPD improve over a 10-year period with treatment. Those affected typically use a high amount of healthcare resources. There is an ongoing debate about the naming of the disorder, especially the suitability of the word borderline. The term originally referred to borderline insanity and later to patients on border between neurosis and psychosis. An interpretation of the disorder now considers outdated and clinically accurate. BPD is characterized by 9 symptoms according to the DSM-5 to be diagnosed. A person must meet at least 5 of the following symptoms: frantic efforts to avoid real or imagined abandonment, unstable and chaotic interpersonal relationships, often characterized by alternating between extremes of idealization and devaluation, also known as splitting, markedly disturbed sense of identity and distorted self-image, impulsive or reckless behaviors, uncontrollable spending, unsafe sex, substance use disorders, reckless driving, and binge eating, recurrent suicidal ideation or self-harm, rapidly shifting intense emotional dysregulation, chronic feelings of emptiness, inappropriate intense anger that can be difficult to control, transient stress-related paranoia or severe dissociative symptoms. Overall, the most distinguishing symptom of BPD are pervasive patterns of instability in impersonal relationships and self-image, alternating between extremes of idealization and devaluation of others, along with varying moods and difficulty regulating strong emotional reactions. Dangerous or impulsive behavior is also correlated with the disorder. Other symptoms may include feeling unsure of one's identity, morals, and values, having paranoid thoughts when feeling stressed, depersonalization, and in moderate to severe cases, stress-induced breaks with reality or psychotic episodes. Individuals with BPD may have comorbid conditions such as depressive or bipolar disorders, substance use disorders, eating disorders, post-traumatic stress disorder, and attention deficit hyperactivity disorder. Emotions. People with BPD may feel deeper and more intense emotions with greater ease and for a longer time than others do. A core characteristic of BPD is affective instability, which manifests as unusually intense emotional responses to environmental triggers with a slower return to baseline emotional state. According to Marsha Linehan, the sensitivity, intensity, and duration with which people with BPD feel emotions have both positive and negative effects. People with BPD are often exceptionally enthusiastic, idealistic, joyful, and loving. Got to get a deep breath here, but may feel overwhelmed by negative emotions, anxiety, depression, guilt, shame, worry, and anger, experiencing intense grief instead of sadness, shame and humiliation instead of mild embarrassment, rage instead of annoyance, and panic instead of nervousness. Studies have shown that borderline patients experience chronic and significant emotional suffering and mental agony. People with BPD are also especially sensitive to feelings of rejection, criticism, isolation, and perceived failure. Before learning other coping mechanisms, their efforts to manage or escape from their negative emotions may lead to emotional isolation, self-injury, or suicidal behavior. They are often aware of the intensity of their negative emotional reaction, and since they cannot regulate them, subconsciously shut their awareness down entirely, since awareness would only cause further distress. This can be harmful since the awareness of negative emotions can alert people to the presence of a problematic situation. While emotional dysregulation is a key feature of BPD, Fitzpatrick argues that dysregulation itself may not be unique to BPD and be shared by other disorders such as generalized anxiety disorder. However, their study did suggest that those with BPD may have a harder time disengaging from their negative emotions, using distractions to manage their emotions, and returning to baseline emotional state. While people with BPD sometimes feel euphoria, ephemeral or occasional intense joy, they are especially prone to dysphoria, unease, or dissatisfaction. Let's see here. Depression and feelings of mental and emotional distress. Zeneria suggests 4 categories of dysphoria typical of this condition: extreme emotions, destructive or self-destructive, feeling fragmented or lacking identity, and feelings of victimization. Within these categories, a BPD diagnosis is strongly associated with a combination of 3 specific states: feeling betrayed, feeling out of control, and feeling like hurting oneself. Since there is a great variety in the types of dysphoria people with BPD experience, the amplitude of this distress can be a helpful indicator. In addition to intense emotions, people with BPD regularly experience emotional liability, changeability, or fluctuation. Although that term suggests rapid changes between depression and elation, mood swings in people with BPD more frequently involve anxiety, with fluctuations between anger and anxiety and between depression and anxiety. People with BPD can be very conscious of and susceptible to their perceived or real treatment by others, feeling intense joy and gratitude at perceived expressions of kindness, and intense sadness or anger at perceived criticism or hurtfulness. People with BPD often engage in idealization and devaluation of others, alternating between high positive regard for people and great mistrust or dislike for them. Their feelings about others often shift from admiration or love to anger or dislike after perceived abandonment or perceived loss of esteem in the eyes of someone they value. This phenomenon is sometimes called splitting. This de-idealization and devaluation can affect interpersonal relationships with those around them. While strongly desiring intimacy, people with BPD tend toward insecure, avoidant, ambivalent, or fearfully preoccupied attachment patterns in relationships. That's insecure, avoidant, ambivalent, or fearful, preoccupied. People with BPD and members of their family are prone to feeling alienated from each other. Parents of adults with BPD are often both over-involved or under-involved in family interactions. Personality disorders in general are linked to increased levels of chronic stress and conflict, decreased satisfaction of romantic partners, domestic abuse, and unwanted pregnancy. According to some research, some people with BPD tend to move quickly between relationships described in at least one case as butterfly-like. Other individuals would instead cling closely to very few relationships, becoming reliant on fewer people than those without BPD. Behavior. BPD is closely linked to impulsive behavior, which can include substance use disorders, binge eating, unprotected sex, or self-injury. Among others, people with BPD might do this because it gives them the feeling of immediate relief from their emotional pain, but in the long term may feel shame and guilt over consequences of this behavior. A cycle often begins in which people with BPD feel emotional pain, engage in impulsive behavior to relieve that pain, feel shame and guilt over their actions, feel emotional pain from the shame and guilt, and then experience stronger urges to engage in impulsive behavior to relive that pain or relieve that new pain. As time goes on, impulsive behavior may become an automatic response to emotional pain. Self-harm and suicide. Self-harming or suicidal behavior is one of the core diagnosis criteria in DSM-5. Self-harm occurs in 50 to 80% of people with BPD. The most frequent method of self-harm is cutting. However, bruising, burning, headbanging, or biting are also common with BPD. It is hypothesized that people with BPD may feel emotional relief after engaging in self-harm. The estimation of lifetime risk of suicide among people with BPD varies depending on the method of investigation. Between 3% and 10%, there is evidence that a considerable percentage of men who die by suicide may have undiagnosed BPD. And if you're suicidal, dial 988, the suicide helpline. I've dialed it before when I've been suicidal, when I've been in crisis. I've dialed 988. I want you to do the same. The reported reasons for self-harm differ from the reasons for suicide attempts. Nearly 70% of people with BPD self-harm without trying to end their lives. Reasons, and it can also include like passive suicidal attempts, like, taking a handful of pills. The person might not have, meant to kill themselves, but that type of behavior is borderline suicidal behavior. It's like passive suicide. Reasons for self-harm include expressing anger, self-punishment, generating normal feelings, often in response to disassociation, and distracting oneself from emotional pain or difficult circumstances. In contrast, suicide attempts typically reflect a belief that others will be better off following the suicide. Sexual abuse can be a particular trigger for suicidal behavior in adolescents with BPD. Sense of self. People with BPD tend to have trouble seeing their identity clearly. In particular, they tend to have difficulty knowing what they believe, what they value, prefer, and enjoy. They are often unsure about their long-term goals for relationships and jobs. This can cause people with BPD to feel empty and lost. Self-image can also change rapidly from healthy to unhealthy. People with BPD may base their identity on others, leading to a chameleon-like changes in identity. Cognitions. The often intense emotions people with BPD experience may make it difficult for them to concentrate. They may also tend to disassociate, which can be thought of as an intense form of zoning out. Others can sometimes tell when someone with BPD is disassociating because their facial or vocal expressions may become flat or expressionless, or they may appear distracted and numb to emotional stimuli. Disassociation most often occurs in response to a painful event or something that triggers the memory of a painful event. It involves the mind automatically redirecting attention away from the current event or situation or blocking it out entirely. This is done presumably to protect against behavioral impulses that present emotive event might trigger. The mind's habit of suppressing and avoiding intensely painful emotions may provide some temporary relief of feelings, but disassociation can also lead to unhealthy coping mechanisms while simultaneously causing the side effect of blocking out or blunted positive emotions, thereby reducing the access of people with BPD to the valuable information those emotions provide. Information that helps to gain effective, healthy decision-making in daily life. Psychotic symptoms. Though BPD is primarily seen as a disorder of emotional regulation, psychotic symptoms are fairly common, with an estimated 21 to 54% prevalence in clinical BPD populations. These symptoms are sometimes referred to as pseudo-psychotic or psychotic-like terms that suggest a distinction from those seen in primary psychotic disorders. Recent research, however, has indicated that there is more similarity between pseudo-psychotic symptoms in BPD and true psychosis than originally thought. Some researchers critique the concept of pseudopsychosis for one top of the week construct validity, the implication that is not true or less severe, which could trivialize distress and serve as a barrier to diagnosis and treatment. Some researchers have suggested clarifying these BPD symptoms, such as true psychosis, or even eliminating the distinction between pseudo-psychosis and true psychosis altogether. The DSM-5 recognized transient paranoia that worsens in response to stress as a symptom of BPD. Studies have documented both hallucinations and delusions in BPD patients who lack another diagnosis that would better account for those symptoms. Phenomenologically, research suggests that auditory verbal hallucinations found in patients with BPD cannot be reliably distinguished from those seen in schizophrenia. Some researchers suggest there may be a common etiology underlying hallucinations in BPD and those in other conditions like psychotic and affective disorders. Disability. Many people with BPD are able to work if they find appropriate jobs and their condition is not too severe. People with BPD may be found to have disability in the workplace if the condition is severe enough that the behaviors are sabotaging relationships, engaging in risky behavior, or intense anger prevent the person from functioning in their job role. The United States Social Security Administration acknowledges affected individuals can apply for disability benefits. As in the case of other mental disorders, the causes of BPD are complex and not fully agreed upon. Evidence suggests that BPD and post-traumatic stress disorder may be related in some way. Most researchers agree that a history of childhood trauma can be a contributing factor, but less attention has historically been paid to investigating the causal roles played by congenital brain abnormalities, genetics, neurobiological factors, and environmental factors other than trauma. Genetics. Compared to other major psychiatric disorders, genetic research in BPD is still in its very early stages. The heritability of BPD is estimated to be between 37% and 69%. That is, 37% to 69% of the variability is liability underlying BPD in the population can be explained by genetic differences. Twin studies may overestimate the effect of genes on variability in personality disorders due to the complicating factors of shared family environment. Even so, the researchers of one study concluded that personality disorders, seem to be more strongly influenced by genetic effects than almost any axis 1 disorder, depression, eating disorders, and more than most broad personality dimensions. Moreover, the study found that BPD was estimated to be the third most heritable personality disorder out of the 10 personality disorders reviewed. Twin, sibling, and other family studies indicate partial heritability for impulsive aggression, but studies of serotonin-related genes have suggested only modest contributors to behavior. Families with twins in the Netherlands were participants on an ongoing study by Troll and colleagues in 711 pairs of siblings, and 561 parents were examined to identify the location of genetic traits that influence the development of BPD. Research collaborators found that genetic material or on chromosome 9 was linked to BPD features. The researchers concluded that genetic factors play a major role in the individual differences of borderline personality disorder features. These same researchers had earlier concluded in previous study that 42% of variation in BPD features was attributable to genetic influences, and 58% were attributed to environmental influences. Genes under investigation as of 2012 include the 7-repeat polymorphism of the dopamine D4 receptor, DRD4, on chromosome 11, which has been linked to disorganized attachment, while the combined effect of 7-repeat polymorphism and the 1010 dopamine transporter genotype has been linked to abnormalities in inhibitory control, both noted features of BPD. There is possible connection to chromosome 5. Brain abnormalities. A number of neuroimaging studies in BPD have reported findings of reductions in regions of the brain involved in regulation of stress responses and emotion, affecting the hippocampus, the orbital cortex, and the amygdala, amongst other areas. A smaller number of studies have used magnetic resonance spectroscopy to explore changes in the concentrations of neurometabolites in certain brain regions of BPD patients. Looking specifically at neurometabolites such as N-acetylapyrrotate, creatine, glutamine-related compounds, and choline-containing compounds. Childhood trauma. There is a strong correlation between child abuse, especially child sexual abuse, and development of BPD. Many individuals with BPD report a history of abuse and neglect as young children, but causation is still debated. Patients with BPD have found to be significantly more likely to report having been verbally, emotionally, physically, or sexually abused by caregivers of either sex. They also report a high incidence of incest and loss of caregivers in early childhood. Individuals with BPD were also likely to report having caregivers of both sexes deny the validity of their thoughts and feelings. Caregivers were also reported to have failed to provide needed protection and to have neglected their child's physical care. Parents of both sexes were typically reported to have withdrawn from the child emotionally and to have treated the child inconsistently. Additionally, women with BPD who reported a previous history of neglect by a female caregiver or abuse by a male caregiver were significantly more likely to have experienced sexual abuse by a non-caregiver. It has been suggested that children who experience chronic early maltreatment and attachments difficulties may go on to develop borderline personality disorder. Writing in the psychoanalytic tradition, Otto Kemberg argues that a child's failure to achieve the development task of psychic clarification of self and other, and failure to overcome splitting might increase the risk of development of borderline personality. Neurological patterns. The intensity and reactivity of a person's negativity, affectivity, and tendency to feel negative emotions predicts BPD symptoms more strongly than does childhood sexual abuse. This finding differences in brain structure and the fact that some patients with BPD do report a traumatic history suggests that BPD is distinct from post-traumatic stress disorder, which frequently accompanies it. Thus, researchers examined development causes in addition to childhood trauma. Research published in January 2013 by Anthony Rucco at the University of Toronto has highlighted two patterns of brain activity that may underlie the dysregulation of emotion indicated in this disorder. Increased activity in the brain circuits responsible for the experience of heightened emotional pain, coupled with reduced activity activation of the brain circuits that normally regulate or suppress these generated painful emotions. These two neural networks are seen to be dysfunctionally operative in the limbic system, but the specific regions vary widely in individuals, which calls for the analysis of more neuroimaging studies. Also, contrary to results of early studies, those with BPD showed less activation in the amygdala in situations of increasing negative emotionality than the control group. John Crystal, editor of Journal of Biological Psychiatry, wrote that these results added to the impression that people with borderline personality disorder are set up by their brains to have a stormy emotional life. Although not necessarily unhappy or unproductive lives, their emotional instability has been found to correlate with differences in several brain regions. Mediating and moderating factors, executive function. While high rejective sensitivity is associated with strong symptoms of borderline personality disorder, executive functions appear to mediate the relationship between rejection sensitivity and BPD symptoms. That is, a group of cognitive processes that include planning, working memory, and attention, and problem solving might be the mechanism through which rejection and sensitivity impacts BPD symptoms. A 2008 study found that relationship between a person's rejection of sensitivity and BPD symptoms was stronger when executive function was lower, and that relationship was weaker when executive function was higher. This suggests that high executive function might help protect people with high rejection sensitivity against symptoms of BPD. A 2012 study found that problems in working memory might contribute to greater impulsivity in people with BPD. Family environment. Family environment mediates the effect of child sexual abuse on development of BPD. An unstable family environment predicts the development of the disorder, while a stable family environment predicts a lower risk. One possible examination is that a stable environment buffers against its development. Self-complexity. Self-complexity, or considering oneself to have many different characteristics, may lessen the apparent discrepancy between an actual self and a desired self-image. Higher self-complexity may lead a person to desire more characteristics instead of better characteristics. If there is any belief that characteristics should have been acquired, these may be more likely to have been experienced as examples rather than considered as abstract qualities. The concept of norm does not necessarily involve the description of the attributes that represent the norm. Cognition of the norm may only involve the understanding of being like or concrete relation and not to attribute. Thought suppression. A 2005 study found that thought suppression, or conscious attempts to avoid thinking about certain thoughts, mediates the relationship between emotional vulnerability and BPD symptoms. A later study found that relationship between emotional variability and BPD symptoms is not necessarily mediated by thought suppression. However, this study did find that thought suppression mediates the relationship between an invalidating environment and BPD symptoms. Developmental theories. Marsha Linehan's biosocial developmental theory of borderline personality disorder suggests that BPD emerges from the combination of emotional vulnerable child and an invalidating environment. Emotional vulnerability may consist of biological, inherited factors that affect a child's temperament. Invalidating environments may include contexts where a child's emotions and needs are neglected, ridiculed, dismissed, or discouraged, or may include contexts of trauma and abuse. Linehan's theory was modified by Sheila Crowell, who proposed that impulsivity also plays an important role in the development of BPD. Crowell found that children who are emotionally vulnerable and are exposed to invalidating environments are much more likely to develop BPD if they are also highly impulsive. Both theories describe an interplay between a child's inherited personality traits and their environment. For an example, an emotional sensitivity or impulsive child may be difficult to parent, exacerbating the invalidating environment. Conversely, invalidation can make an emotional sensitive child more reactive and distressed. Diagnosis. Diagnosis of borderline personality disorder is based on clinical assessment by a mental health professional. The best method is to present the criteria of the disorder to a person and to ask them if they feel that these characteristics accurately describe them. Actively involving people with BPD and determining their diagnosis can help them become more willing to accept it. Some clinicians prefer not to tell people with BPD what their diagnosis is, either from concern about the stigma attached to this condition or because BPD used to be considered untreatable. It is usually helpful for the person with BPD to know their diagnosis. This helps them know that others have had similar experiences or have had similar experiences and can point them toward effective treatment. In general, the psychological evaluation includes asking the patient about the beginning and severity of their symptoms, as well as other questions about how symptoms impact the patient's quality of life. Issues of particular note are suicidal ideation, experiences with self-harm, and thoughts of harming others. Diagnosis based both on the person's report of their symptoms and on the clinician's own observations. Additional tests for BPD can include a physical exam and laboratory tests to rule out other possible triggers for symptoms, such as thyroid conditions or substance use disorder. The ICD-10 manual refers to the disorder as emotionally unstable personality disorder and has similar diagnosis criteria. In the DSM-5, the name of the disorder remains the same as the previous editions. Diagnosis and Statistical Manual. The Diagnosis and Statistical Manual of Mental Health Disorder 5th edition has removed the multi-actual system. Consequentially, included personality disorders are Section 2, and then it goes on and on and on, guys. I'm just going to see if I can read something in closing. All right. The World Health Organization ICD-11 completely restructured its personality section. It classified BPD as personality disorder, borderline pattern described as the following. The borderline pattern specifier may be applied to individuals whose pattern of personality disturbance is characterized by a pervasive pattern of instability of interpersonal relationships, self-image and effects, and marked impulsivity. Hold on one second. Marked impulsivity as indicated by the following. Frantic efforts to avoid real or imagined abandonment, a pattern of unstable and intensive personal relationships, identity disturbance manifests in markedly and persistently unstable self-image or sense of self, a tendency to act rashly in states of high negative effect, including to potentially self-damaging behavior, recurrent episodes of self-harm, emotional instability due to marked reactivity of mood, chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, transient dissociative symptoms or psychotic-like features in situations of high affective arousal. Other manifestations of borderline pattern, not all of which may be present in given individual at a time, include the following. A view of the self as inadequate, bad, guilty, disgusting, or contemptible. An experience of the self as profoundly different and isolated from other people, a painful sense of alienation and pervasive loneliness. Proneness to rejection and hypersensitivity, problems in establishing and maintaining consistent, appropriate levels of trust in interpersonal relationships, a frequent misinterpretation of social signals. And then, there's the impulsive type borderline, F1630, at least 3 of the following must be present. Marked tendency to act unexpectedly and without consideration of the consequences. Marked tendency to engage in quarrelsome behavior and to have conflicts with others, especially when impulsive acts are thwarted or criticized. Liability to outbursts of anger or violence, which with inability to control the resulting behavioral explosions. Difficulty in maintaining any course of action that offers no immediate reward. Unstable and capricious, impulsive, whimsical mood. And then the borderline type, at least 3 of the symptoms mentioned in impulsive type must be present. Disturbances and uncertainty about the self-image, aims, and internal preferences. Liable to become involved in intense and unstable relationships, often leading to emotional crisis. Excessive efforts to avoid abandonment, recurrent threats or acts of self-harm, chronic feelings of emptiness, demonstrates impulsive behavior, speeding in a car, or substance use. And then there's subtypes. There's a discouraged borderline, including avoidant and dependent features. The petulant borderline, including negativistic features. Impulsive borderline, including histrionic and antisocial features. and the self-destructive borderline, including depressive and masochistic features. So we can go into those later. It'd be kind of like a cool video on its own to discuss those, right? Anyway, guys, I think that's going to do it for today. I think that's going to do it for today's reading, guys. Thank you guys so much for tuning in to Rap Star channel. I do karaoke, mental health videos, Amazon videos, Helium 10 videos. I'm an affiliate for Helium 10, which is a California company. You can use my code GetCheddar20 to get a discount at helium10.com. You can also check out my brand Faith Rising, which is FAITHRIZING. Filter for new releases. That is my merch. Got 500 shirts listed on Amazon. You can filter for new releases. And if you guys haven't subscribed to Rap Star, you can push the subscribe button, push the like button. To the next reading, guys, that is a direct reading from Wikipedia. So that's Wikipedia. So that's https://en.wikipedia.org/wiki/borderline personality disorder. So thank you, Wikipedia. I wanted to read right from Wikipedia so we could get it right, guys. We got it right. We got it done. Don't forget to subscribe, like this video, share it with a friend. Till next time, Steve signing out.